few cases. So as we everyone know, sometimes for a simple disc which is lying laterally with a good disc height, we tend to do fusion. So definitely we can avoid sometimes the fusion related concepts for a simple discectomy, where in lumbar we just do a simple fragmentectomy most of the time. In cervical also, for select cases, definitely there is a very good uh, approach we can use, because to avoid these complications, as a open surgeon or as a minimal invasive surgeons, you might have encountered these complications when you follow up your own patient for longer time. So definitely it's not that all discectomies or all cases can be approached through endoscopy. As a beginner, your indication should be very strict initial part of your career, otherwise the failures are high. So multi-level disease, axial neck pain, and calcified discs and central herniation should be avoided, or you can say it's a contraindicated. So you have this in your scope. So it's you use a regular scope for. I use a similar discoscope which we use for interlaminar. This is a special scope device, a further smaller scope, working channel of 3.1. But I use a regular scope which we use for lumbar discectomy. So the concept here is where you want to land. It's same as open surgery. We land in the what to say area of facet lamina junction, as in microscopic decompression of laminoformatomy surgery. So this is very important marking for a beginner, because once you mark a midline, the second line would be the medial facetal line, so or laminofascial junction. That line should be marked, and in lateral you should mark in line with the disc space so that it is easy. If you don't have a radio lucent table, sometimes the lateral becomes difficult, or AP becomes difficult. So you need to understand or have an idea of if sometimes we take only AP and do C6-7. So that technical difficulties might come on which table you are operating sometimes. And always try to keep the table in line with your work, otherwise the C6-7 sometimes become too angulated, so you might have a difficulty operating. So make the table more horizontal so that you don't work too oblique. So it's again, I'll just skip this slide. So anyway, I will show you the video. So this is what I was talking about. You see the anatomy here. The root is just medial to the facet, and that bone covers that area. So where we need to decompress, it is only few millimeter. So there will be a lot of blood vessels around it. So in open surgery or microscopic surgery, we all have gone there before. So it bleeds a lot. So you just keep on packing your cottonoids. But here that's the biggest advantage, where you don't have that issue of bleeding here. So all you have to drill is a bit of upper descending facet, ascending facet, and a bit of lamina. So for example, in this case, you can see acute C5-6 PIVD lateral disc. So the position would be patient under GA, just little neck flexed so that your interlaminar window opens up. This is so then you give a small, once you have marked, you give a small nick around 7 mm. Once it is done, you use a dilator as we use. So here again, the dilator should not be too oblique. You will go to the opposite side. It should be just paramedian like this. Once it is there, you are touching the bone, you would land on the facetal area, then you just take the sheath in. So here, because we are doing monoportal, your hemostasis and bleeding issues will not be there. So once you go there and you take this, so here you see the working would be more vertical. You are not too oblique, so that's how you try to manage it. Once you go there, this you have to decide, this you have to define. This I'll show you in the next video, so I'll just skip this for lack of time. So this is what we have to define: the lamina, both upper and lower lamina, and the joint area. So then you can use either diamond drill or a protected drill like this. So depending upon your expertise, once you have done that, you see this, you go there and you can just remove the, so that's a root. I'll just show you in the next slide. So what just I want to show you here is the amount of bone drilling we do here. It's just 1 or 2 mm facet loss will be there, and it's another case. Again the position, so same. So the idea is to keep the patient more neck flex little bit, so that you can have a good space, working space. So that's the edge of lamina. You can see that that's a facet, descending facet, is ascending facet, and this is the lower lamina. So don't remove the ligament too much initially. Always protect the ligament so that you can work better. So that V, demonstration of that V is very important, so that you can drill better. So this once you drill it, you see the root, then you just remove the. So the definition of the upper defining the upper margin and the lower margin of the root is key here. So this is post-op. So one more case here. So again, this you can see the position here. This is very important. Too much flexion is also not required. Just to open up the space, you can just make neck a little bit flex there. So what I was telling is the definition of defining the upper and lower margin of the root is essential, so that you don't struggle as a beginner. So then MRI, you should read MRI whether your fragment is in the shoulder or in the axilla. Most of the time here in cervical, the fragments are in the axilla, but you do get the fragments in the shoulder also. So reading the MRI is the key, so that you can drill more upper the cranial or caudal. So some people practice they drill till the flush to the pedicle in the cranial side, so that it is easy to reach the shoulder. So you can see the fragment is in the axilla here. So it's very easy that you can just go and grab it and come out. So once it is done, you can check whether anything is in the shoulder or axilla. The trick is don't go beyond this. There is a fascia here. Don't go beyond that. That fascia coincides with your vertebral artery deeper, more anteriorly. So don't go beyond this fascia here, the laterally. So the bleeder, the venous lake starts there, and you will encounter a vertebral artery anteriorly. So you just come out with a small disc fragment there. There's one more case again, C56. You can just remove both. You can see cranial and caudal. I'm just coagulating. Here you can see the fragment is in the shoulder here. So previously we saw the fragment was more in the axilla. Here the fragment is more towards cranial. So it is imperative that you look, you clear the both cranial and caudal. So here I have little bit drilled more cranial, so that it's more easy to reach the fragment. Sometimes fragment is bang just anterior to the root. So you need to have a good window to work. Once you open the canal, sometimes it becomes difficult for a beginner to drill the bone. So then don't too much expose the epidural space here. So previous discussions we were discussing the chance of the saline seepage is high. So don't use a pump, or if you are using a pump, 30 to 40 should be your pressure, and don't too much expose the epidural space so that saline seeps into the epidural space more. So this is just a post-op. So uh, because we are discussing here, so this can be extended to decompression also. This was a previous ACDF case. Just 1 minute, I'll take 1 minute. So the patient still has a canal stenosis. Such cases we can do posterior approach, do the decompression, and you can see the entire ligament is removed, and this is post-op. So you can do a good decompression. Sometimes multi-level canal stenosis you see, and you can see the single entry where we have reached the upper level and lower level. Two lamina, two spaces we can reach easily. So this is a post-op. You can have a good decompression with a single entry. Thank you.